All right, so today's presentation is a collaboration between Justice and Aging, formerly the National Senior Citizens Law Center, and the Disability Rights Education and Defense Fund. And today we're going to be covering the Coordinated Care Initiative, and specifically we're going to be doing what we call an advanced presentation, where we're going to cover in more detail the benefit package and consumer protections. So hopefully most of you that are in attendance today have listened to the basics training, so have a pretty good understanding of the CCI, because this goes a bit more into depth about the program. Justice and Aging is a nonprofit. We have offices in Washington, D.C., Los Angeles, and Oakland. I'm based out of the Los Angeles office. And we focus primarily on the public benefits program that impacts seniors and persons with disabilities with low incomes. So we focus on the Medicare program, the Medicaid program here in California, the Medi-Cal program, and supplemental security income. And then, Silvia, do you want to say a little bit about DREDF?
Sure. DREDF has been around since 1979. We're founded by people with disabilities and parents of children with disabilities. They're also on our board, and we focus on law and policy that is of concern to people with disabilities. We're based in Berkeley, California, and our interest is in protecting and advancing civil and human rights of people with disabilities.
Great. So just an outline of today's discussion. We're going to do a brief overview of the Coordinated Care Initiative just to get us all on the same page. We'll talk about the integration of long-term services and supports. We'll go into more detail about what the benefit package looks like, particularly for Cal MediConnect. And then we're going to end with a review of the consumer protections, or the major consumer protections under the Coordinated Care Initiative. So before we start off, I always like to start with a glossary to make sure that we're all on the same page with regard to definitions. So the first definition I'll start with is a dual eligible, or a dual, Medi-Medi. That is someone who has both Medicare and Medi-Cal health insurance coverage. That is one population that is impacted by the Coordinated Care Initiative. The other population impacted by the Coordinated Care Initiative is the very last bullet, the seniors and persons with disabilities, or SPDs. These are individuals who have Medi-Cal only coverage, so they don't have Medicare, Medi-Cal only, and the basis for eligibility for that Medi-Cal is either age or a finding of disability. Another term I like to define is a dual special needs plan, or a DSNP. That is a special type of Medicare Advantage plan. So a Medicare Advantage plan are one of those plans that if you have Medicare, it's kind of Part C, you can buy into a private HMO or PPO plan for Medicare. And under that umbrella of Medicare Advantage plans are these things called dual special needs plans. So they're a special type of Medicare Advantage plan targeted specifically at dual eligibles. So they're no cost, and they're supposed to provide some different coordinated benefits that are particular to the needs of dual eligibles. And individuals enrolled in these dual special needs plans are impacted differently under the CCI than individuals who are not enrolled in these types of health plans. And then finally, I like to define long-term services and supports, or LTSS. Under the CCI, that has a very specific meaning. Generally, you can speak about LTSS very broadly, but under the CCI, it encompasses 4 Medi-Cal, primarily Medi-Cal funded programs. So it's the In-Home Supportive Services Program, or IHSS. That's where you have a provider, usually a friend or family member who comes in and helps with activities of daily living. The consumer has the right to hire, fire, and supervise that IHSS provider. Then there's the Community-Based Adult Services Program, formerly known as Adult Day Health Care. This is where individuals go to sites and receive a range of services: socialization, nutrition, nursing services. And the goal of those CBAS centers is to help someone continue living in the community rather than going into an institutional setting like a nursing facility. Then there's the Multipurpose Senior Services Program, or MSSP. This is an intense case management program available to individuals 65 or over, again, aimed at keeping people out of nursing facilities and living in the community. And it's pretty limited in the sense that it's a waiver program, so that there are only so many slots available to individuals, but it's incredible, intense case management, keeping people living at home. And then finally, the nursing facility benefit. So these four primarily Medi-Cal funded benefits fall under that umbrella term of LTSS. So when we're discussing LTSS, we're really talking about those four covered benefits. All right, so, and if there's any problems with the sound, do let me know. I don't know what would be causing it. It might just be our phone systems, but I will try to slow down a little bit and make sure that I repeat myself in the event that I am breaking up. Just to review what the Coordinated Care Initiative is, it encompasses three major changes. The first is that pretty much if you have Medi-Cal, you're going to have to be in a managed care plan to continue receiving your Medi-Cal benefits. This started back in 2011 when we saw individuals who only had Medi-Cal, our SPDs. They were mandatorily transferred or mandatorily transitioned into managed care plans. But in that transition, there were major carve-outs. So, for example, if you were living in a nursing facility, you did not need to be in a Medi-Cal managed care plan. If you had a share of cost, you did not need to be in a Medi-Cal managed care plan. If you were dually eligible, if you had both Medicare and Medi-Cal, you did not have to be in a Medi-Cal plan. Under the CCI, that changes. If you have Medi-Cal, you're going to have to join a managed care plan of some sort to continue receiving that Medi-Cal benefit. Very few exceptions to that. The second major change is that the plans, the managed care plans, are now going to become responsible for the long-term services and supports. So CBAS and IHSS and MSSP, and most notably nursing facility, are all benefits that now the managed care plans are going to be responsible for. And to give a really concrete example of that, I like to talk about the nursing facility benefit because it looks the most different moving into managed care. CBAS went in already in 2012. IHSS is going to look pretty much the same to consumers of IHSS. MSSP at this moment looks the same, but nursing facility looks pretty different. In the past, prior to the CCI, if you were someone who was living in the community, you were in a Medi-Cal plan, you went to the hospital and you were discharged to a nursing facility, you were then disenrolled from your Medi-Cal plan and put back in fee-for-service. So basically, you could go to any nursing facility that accepted Medi-Cal. Under the CCI, you're in a plan, living in the community, you go to the hospital, you're going to be discharged to a facility. Now you're going to have to choose a nursing facility that is within your health plan's network. So now it needs to be a network provider. A nursing facility is now part of the providers that you have to see are part of your plan. So just like your primary care physician or a specialist, you're going to have to pick a nursing facility that is within your health plan's provider network. So that looks very, very different than it used to look prior to the CCI. The third major change, and the one we hear the most about, is the Cal MediConnect program. This is a new type of health plan that combines someone's Medicare and Medi-Cal benefits into one health plan. So one health plan is delivering both sets of benefits, both the Medicare benefit and the Medi-Cal benefit, including those long-term services and supports. This is a voluntary program, meaning that you don't have to join a Cal MediConnect plan. It's only available to dual eligibles. You have to have both Medicare and Medi-Cal. Keep in mind, though, that even if you don't participate in Cal MediConnect, you are still going to have to be in a managed care plan for your Medi-Cal benefit. That is mandatory. All right, so again, to reiterate who's impacted, it's individuals who have both Medicare and Medi-Cal are dual eligibles or Medi-Medis, and then those with Medi-Cal only are seniors and persons with disabilities or SPDs. Individuals who only have Medicare are not impacted by the CCI. hold on just a second. So exactly who is impacted? Actually, Silvia, were you going to take over here? I don't have my...
Sure, Amber. Let me just take myself off mute.
What? I can't remember. I'm sorry. Where the breakup was.
Yes. I think it was a little later, but if you want, I can take over here.
Nope. I'll go ahead. I just I didn't have the slide breakdown in front of me. All right.
Okay. But I think the break is I hear a lot of breaking up, so I'll put myself on mute, and maybe that will help. Hopefully.
Okay. To that. But when it comes to Cal MediConnect, it gets a lot more complicated. So if you have a dual who's excluded from Cal MediConnect, so that meaning that they pretty much can't participate even if they wanted to. That includes people who have end-stage renal disease, ESRD, who require dialysis. Of course, there's an exception to that. If you live in San Mateo or Orange County, that does not apply. If you reside in certain zip codes within an LA County, Riverside, and San Bernardino, you can't participate. If you're a resident of a VA home, if you're a resident of an ICFDD, you have a shared cost met. You have maybe you have Medicare, but you also have some private health insurance through your former employer. You're excluded from Cal MediConnect, or you're in a DDS waiver or receiving services from a regional center or developmental center. I've marked there in that column with the double stars those individuals who are entirely excluded from the CCI. So, for example, if you're a resident of an ICFDD, you shouldn't be getting any notices about the CCI, Cal MediConnect or otherwise. The rest of the groups are individuals who should not get any notices about Cal MediConnect, but will get notices about the joint plan. Then there are individuals who participate in Cal MediConnect, but who aren't going to receive notices about Cal MediConnect. For example,
Amber? Oh. I'm
I just
sorry.
got your message.
Yes, I think the breaking up has been just escalating for just over this last slide. So I think we're going to ask you to phone in again. It might be just a bad connection, and I'll finish up this slide. Does that work?
Yes, it totally works.
Thank you. Okay. Sorry, everyone, for that. I guess we just all have to live with bad connections for a bit. I'm going to go on from where Amber stopped. I know that it was hard to get that first part about duals who are excluded from Cal MediConnect, but we can, if any of you would like us to go over that again, please, you can put that suggestion in the chat box. And there are also, this list is also detailed in other places as well, and we can provide that information. In terms of the CCI and who is impacted, there are a number of dual eligibles who can participate, who can choose to do so, but have to actively do so. They will not be passively enrolled. If they do nothing, they will not be enrolled. So that includes those who are already enrolled in the PACE program, those who are enrolled in the AIDS Healthcare Foundation waiver. There are individuals who live in certain zip codes in San Bernardino County, and these are primarily sort of rural areas, and they will also not be passively enrolled. And then there are a number of individuals, those who are already enrolled in Kaiser, or those who are in who are in a DSNP plan that is with a health plan that is not involved in Cal MediConnect, those who are in a Medicare Advantage plan. And then there are also these other very sort of specialized special needs plans that you will not be passively enrolled. If you're already an individual who is at a nursing facility waiver, any of the home and community-based service waivers, or the HIV/AIDS waivers, assisted living waivers, you will not be passively enrolled. You are, in fact, supposed to be receiving integrated services now under the waiver. So that's one of the rationales for you not being passively enrolled in yet another program. So if Amber is back, I'm going to go on to the next page and let Amber continue.
I am here. Is that better?
Great.
Yay. Okay. All right. So with this really complicated group of people, some are excluded, some are not excluded, some should get one set of notices versus a different set of notices. The Department of Healthcare Services has set up an email address when people receive the wrong notices that you can email to this email address and let them know. So there are instructions here on what type of information should be provided. You're not supposed to send personal private health information. They'll send you a secure email back to provide that information. And then if you're not the person's representative, they may not give you case specifics moving forward. But the goal of this email address was in order to help fix the problem when wrong populations were receiving wrong notices. So I do recommend that people use this email address for that problem. And then just to keep in mind, again, that even individuals who do not receive notices about Cal MediConnect most likely are going to receive notices telling them that they have to enroll in a Medi-Cal plan. That is pretty much mandatory for everyone except for a few populations. So you're going to find yourself as a dual. You might be in fee-for-service for your Medicare, but your Medi-Cal plan is going to be responsible for your Medi-Cal services. All right, Silvia, I do think it's time that that we switch over. But I would like to stop there to make sure that there aren't any questions. And I don't
think there were any.
No.
There's one attendee who put up their permission to speak button on, but I'm not sure if that, we'll just wait a little bit. I'm not sure if that was actually a real question or not. So we'll just continue a little bit. How about that? So going on, let's look a little bit more at the actual benefit packages. And looking first at Medi-Cal managed care. So Medi-Cal managed care does now have these two components. It includes the medical care, the kind of care we often associate with a health plan, going to doctor's offices, hospital care, et cetera. And now it also includes long-term services and supports, which is this new, very, very large change. That's now included in Medi-Cal managed care. Medi-Cal has always been a primary source of long-term services and supports. Medicaid is essentially the provider of home and community-based services and long-term services in the country. But now it's also included under the auspices of managed care, and that's the big change. There are a couple of additional Medi-Cal benefit changes that have happened in the last 2 years that will be very interesting to Medi-Cal beneficiaries and to their advocates. On January 1st, 2014, there was a new mental health benefit that was announced, which is now available to all Medi-Cal recipients. And it's a Medi-Cal benefit that is delivered through Medi-Cal plans. There is now a differentiation between the levels of mental health care that may be needed. What Medi-Cal plans are supposed to deliver now is mental health care that is of a less, I guess you could see it as a less serious order. They will provide group therapy, certain kinds of therapies, mental health assessments, testings, that kind of thing. So that's now available through Medi-Cal plans. There's now also a Medi-Cal dental benefit that started on May 1st, 2014. So that is a basic Medi-Cal benefit that will for dental health. But this is actually not delivered through Medi-Cal plans. It's a carve-out. The dental benefit is delivered through Denti-Cal. And the health plans do not have a primary responsibility for delivering that, though they should at least be open to coordinating with dentists where that's necessary. Let's say for someone who needs anesthesia with their dentistry. So going on and looking a little more closely at long-term services and supports and managed care, Amber spoke about these briefly at the beginning, but we'll look at them in a little more detail. The four programs that are now under the flag of managed care are the community-based adult services. These are homes and programs where often seniors and people with disabilities, people who are Medi-Cal, can go during the day, where they receive some health care if that's necessary. It's a place where they receive services and supports during the daytime, but only the daytime. Then they go back to their own home. Also, there's in-home supportive services, which is a very critical and component of long-term services and supports. It allows seniors and people with disabilities who need assistance with daily living to remain in their homes. It's a program that has been developed and is very dear to the hearts of many, the disability community and many individuals in California because of the way that it allows people with disabilities to actually have control over the provider who helps them in their home, since the individual, the Medi-Cal beneficiary is the one who hires and fires, helps to train and supervises the provider who comes to their home. And as Amber has said, many of these individuals, providers, are friends or family members who are being paid to assist the person with a disability. The multi-service seniors program is one directed towards seniors and provides them with a variety of services, including home supports, Meals on Wheels, some health care that can come to the home. And again, it's designed to help individuals remain in their home to age in place or to live in the community while receiving services in the community. And then finally, the nursing facility is that component in which individuals do go to an institution, will remain, stay in a home, etc. That is not in the community. It is where they will live and reside, and is a matter of that now managed care organizations will be making contracts with nursing facilities, and nursing facilities will be paid through managed care organizations for their Medi-Cal, the Medi-Cal individuals who live in their home. Moving on now from straight Medi-Cal on to Cal MediConnect benefits. There are required benefits under Cal MediConnect. So these are benefits that are only available to those who are duly eligible for Medicare and Medi-Cal and who have elected to join the Cal MediConnect plans. Of course, Medicare A, B, and D, so that includes your office visits to a provider, therapy, and hospitals and pharmacy services. The Medi-Cal services include what I just spoke about on the last slide, all the in-home supportive services, community-based adult services, nursing facilities, and the multi-service seniors program. It also includes a vision benefit, just a fairly basic benefit. You get one routine eye exam annually and $100 towards eyeglasses or contacts every 2 years. There is also a transportation benefit. It's medical in that it's transportation to your medical services, an appointment, therapy, etc. These are 30 one-way trips per year. It's not medical in that it's not an ambulance. These are just essentially taxi rides or other ways of getting towards your transportation. And you have 30 of them for 1 year, which is sufficient for some people and not sufficient for others who have many visits to go and many providers. So that's something to work out with your plan and to be aware of as well. And then there is a care coordination benefit. which is a very large component of Cal MediConnect. Looking at it more closely, the care coordination can be very, very valuable to many individuals in the community who are dealing with multiple providers, multiple conditions, other issues happening in their lives, lots of scheduling. The care coordination benefit is offered by the plan, and there's really a number of things to note about it. It is supposed to be person-centered. So the beneficiary, the Medi-Cal beneficiary, is very much supposed to be at the center of the care coordination. It's up to the beneficiary whether they want care coordination and how much of it they want, how much assistance they may want. It is supposed to focus on the needs of the individual and their goals, and also focus on the least restrictive setting for that individual. So if someone is a senior is living in their home, they break a hip, they have other conditions that are happening, the care coordination team and service should be one that speaks with you and with your family, or with your advocates, to work towards a care setting for you, temporary and long term, that is focus more on the community as much as possible. And there should not be any jump towards, well, I guess now it's time for a nursing home. And that's an important thing to think about. There's a health risk assessment that is supposed to happen for all new members coming into a managed care plan, and that will look at the overall needs, and again, the overall needs and goals of the person entering the plan, including any need for long-term services and supports in the community, as well as medical needs. There is supposed to be an individualized care plan for those who enter and who indicate that they would like one and who need one. So it is again supposed to be focused on the needs and the goals and desires of the individual, and an interdisciplinary care team, which will involve not only your medical doctors and your medical providers, but also any social workers, any mental health providers, and your in-home supportive, your IHSS worker, if that is your desire, your family members, if that is your desire. Again, it's supposed to be focused on the needs and the desires of the dual beneficiary, him or herself. There is also additional information in the actual policy letter. You can see at the bottom of the slide the address where the Department of Healthcare Services has put up their policy letter about care coordination, and that's a good document to go through if you're an advocate. And finally, there are some Cal MediConnect benefits that are optional. These are not required from the plan, but the plan can choose to give them in cases where they're needed. They're home and community-based like supports and services. So if you need extra hours because to stay safely in your home, or if you or just to make it better for you to stay in your home, they are discretionary. They are also, note that they are in addition to, not as a trade for other required benefits. So, for instance, if you're someone who doesn't use CBAS and or you want to have less, you're thinking maybe I'll use less CBAS and I'll get more in-home supportive services hours. It can't be a trade. If the assessment is you need this many hours of CBAS, you will get that, and then if you need more IHSS-like services, you can ask for those. And the need for these are supposed to be assessed during the health risk assessment at that beginning when you enter as a new member into the health plan. If you receive some of these services, or if you request some of these services and they're denied, you can appeal that decision. It's an appeal through the plan complaint and grievance process, not through the state, because these are not required services, they are optional services. Again, there's additional information on that at the Dual Demo Advocacy website that Justice and Aging runs, and also there's a policy letter from the Department of Healthcare Services on this. And I think we are now back to Amber for the rest of for some more slides.
All right, I'm here. And I don't think that there are any questions here, so we're going to go ahead and move forward. One of the major problems that we've seen so far with the rollout of the Coordinated Care Initiative is there's been a high percentage of opt-outs, meaning people dual eligibles who have decided that they do not want to participate in Cal MediConnect. So that means that their Medicare is in fee-for-service and hasn't changed, but their Medi-Cal is now in a health plan. And that's caused a lot of confusion for both the duals who are impacted and for their providers. So I just wanted to include a slide that shows what happens when a dual eligible opts out of Cal MediConnect and what Medi-Cal is responsible for. So in that instance, the Medi-Cal plan is going to be responsible for benefits that Medicare does not pay for. Most notably, that's going to be the long-term services and supports. Medi-Cal is the primary funder of those. So the Medi-Cal plan is responsible for coordinating the in-home supportive services, MSSP, CBAS, and ultimately long-term nursing facility care, since Medicare only pays for a small portion of any nursing facility stay. The Medi-Cal plan is also responsible for Medi-Cal transportation services. So, for example, if you are someone who needs to go to medical appointments by a litter van, the Medi-Cal plan is going to be responsible for paying for that vendor of that transportation service. We've seen, as the rollout of the CCI has happened, that the plans aren't necessarily contracted with the same transportation vendors that the dual was using previously. So while there might be a change in the vendor of the transportation service, in theory, there should be no disruption in the provision of that transportation benefit. That's not always been the case. We've seen some major transportation issues, for example, going to dialysis centers where transportation has been disrupted. And I highly recommend calling the CCI ombudsman in those situations because they can quickly work with the health plans to get that transportation benefit set back up so that the member is not experiencing or the beneficiary is not experiencing any disruption in their care because their transportation vendor has changed. Not that they're losing that benefit, but that the vendor of that service has changed. The same goes with certain prescription drugs, Medi-Cal covered supplies, so incontinence supplies, some diabetic supplies. Those are covered by Medi-Cal and not by Medicare. Again, the vendor may change, but there should be no, in theory, disruption in the provision of those supplies or that transportation benefit. And again, if there is a disruption, you should work with the CCI ombudsman to get that back in place because they've been really good at being able to work with the health plans to make sure that that disruption is minimized if there is any. Finally, and this is probably the most confusing aspect, is that the Medi-Cal plan is responsible for paying the cost sharing, the 20%. So in theory, if you go to a Medicare doctor, the Medicare doctor gets paid 80% from Medicare. And then that Medicare doctor can bill Medi-Cal for the 20%. Most times that 20% isn't payable because it's only payable up to the Medi-Cal rate, and that is so much lower than the Medicare rate that most providers who serve dual eligibles never see that 20%. But in any case, if the Medicare provider wanted to bill the 20% before the CCI or before the dual had to join a Medi-Cal plan, they would just bill the state, and the state would pay the 20% if it was payable. Now, the difference under the CCI is that instead of billing the state, the provider bills the Medi-Cal plan. But nothing else changes, just the payer changes. And the Medicare provider does not need to be contracted with the Medi-Cal plan to bill the Medi-Cal plan for the 20% cost sharing. But that's caused a lot of confusion. So we hear a lot of times where someone will go see their Medicare doctor and their Medicare doctor will say, sorry, I can't see you anymore because I don't work with your Medi-Cal plan. That is an education issue. It's not really a problem. They can build a Medi-Cal plan. They don't have to be contracted with the Medi-Cal plan in order for them to get paid if they're actually going to get paid. Or sometimes we hear where the Medicare doctor will say, well, now you're responsible for the 20%. And that's illegal. That's called balance billing, and duals aren't allowed to be balance billed, generally speaking. So That should not be happening, but it's a huge area of confusion. There are a number of fact sheets that are available in the provider toolkit on the Cal Duals website that I recommend using if you're having a provider that is saying that they're not contracted with Medi-Cal plan, can't see you anymore, in order to educate that provider. The state and we and other organizations are trying to do a massive education and outreach kind of campaign to try to nip this in the butt, but it is a pretty big issue causing disruption where there doesn't need to be disruption. All right, and then now on to some consumer protections, and the big one being continuity of care. So that continuity of care means that an individual who enrolls in a health plan has the right to continue to see a provider that is outside of the health plan's network for a certain period of time, as long as several criteria are met. So for Medicare under Cal MediConnect, it's 6 months, and if we're talking about Medi-Cal, it's 12 months. So and that's the baseline. Keep in mind that this is all baseline, that the health plans can go above and beyond this, but this is the required baseline that health plans have to provide in terms of continuity of care protection. So the first criteria is that there must be a pre-existing relationship with the provider. So it can't be someone you've never seen before that's out of network. You had to have had some relationship. And that's defined as at least seeing your primary care physician at least once in the previous 12 months, and if it's a specialist, twice within the previous 12 months preceding enrollment. And the plan is supposed to use utilization data to see if there's that pre-existing relationship. So it's not the member of the health plan that has to prove that pre-existing relationship at the outset. The plan is supposed to look at utilization data to see if they've seen that provider within the last 12 months. And then if the plan doesn't see it in the utilization data, the member can provide proof of that relationship. The provider also must agree to accept payment from the health plan. And what that usually means is just a one-page agreement with the health plan that says, I'm going to accept payment for this specific member. And keep in mind that the health plan has to pay the provider the same rates that they got under fee-for-service. So if it's a Medicare provider who is seeing someone under continuity of care, they're going to get the same rate, a Medicare rate, that they would have received if they were just seeing the person through fee-for-service. And then finally, the provider can't have any documented quality of care concerns. In the plan's contracts, there are certain things set out that say, if a provider is providing really terrible care, that the health plan doesn't have to work with them. So they can't have any documented quality of care concerns. There are some exceptions to the continuity of care policy. So generally it's a 6 month, 12 months, and it's for, seeing all of your doctors and providers. But there are some exceptions. So nursing facility is a big exception. If you are residing in a nursing facility and you're enrolled into a health plan, you have the right to continue to reside in that facility for the length of the demonstration. And so that means that just because you're in an out-of-network nursing facility, you don't have to move just because it's out of network. You have the right to continue residing in that facility. So that's a pretty good consumer protection for residents, so that they don't have to leave their home just because they're in a facility that's not in their health plan's network. Now, if they're not in a facility and they're going into one, they're going to have to choose a facility that is within their health plan's network. Another major exception is durable medical equipment, but this kind of goes in the opposite way. It's more narrow in that continuity of care does not cover durable medical equipment providers. So it covers the service, so you can continue to get your durable medical equipment, but it's not going to allow, the continuity of care protection is not extended to the provider of that service. So you might have to switch providers of your DME. The same goes with ancillary services. For example, maybe you're using a specific lab. You can continue getting lab services, but you might have to use a different lab. And then, of course, with carved out services, so like behavioral health, that's provided by the county, dental, that's provided by Denti-Cal. The health plans have no responsibility to provide continuity of care in those circumstances. And then finally, IHSS, continuity of care really doesn't apply here because under IHSS moving into managed care, you always have the right as a consumer to hire, fire, and supervise your IHSS provider. And then when it comes to continuity of care with prescription drugs, it looks a little bit different. You have the Part D rules apply. So you're going to get one-time refill of a 30-day supply unless there's a lesser amount prescribed. So maybe you were only prescribed a 15-day amount. That's what you would get continuity of care for. And then it's of any ongoing medication within the first 90 days that you're in the plan. So there should be no reason when you join a Cal MediConnect plan that you should be told by your pharmacy that they won't give you your prescription drug, because even if it's not on the formulary, continuity of care should cover it. The problem, though, is that the pharmacies don't always know this. And so there's been some outreach to the pharmacies to let them know that continuity of care is in place and that even if you're in a new health plan, that health plan is going to have to cover that refill at least for a 30-day refill. There are additional protections when it comes to prescription drugs if you're in a nursing facility or institution. And just to know that these transition rules apply to both drugs that are covered only by Medi-Cal and the drugs that are covered by Medicare. So it's a pretty good continuity of care protection. It's not always playing out so expansively in practice, but we're hoping that will continue to get better as pharmacies learn more and more about that protection. Then there are other general protections that are available if you're getting an acute or serious chronic pregnancy, terminal illness, or if you're having any of those services, continuity of care must be provided pursuant to the California Health and Safety Code. And then there were some updates that were made to the continuity of care policy. Providers can request continuity of care, so it's not just the member of the health plan that can request it, but actual providers can request continuity of care. Requests must be processed within 3 days if there is a risk of harm to the beneficiary. Retroactive continuity of care is permitted, meaning that, let's say you didn't know that you were enrolled in Cal MediConnect. You go to the provider, and your provider doesn't know that you were enrolled in Cal MediConnect and renders services. And then they later go to bill, and they find out you're in a Cal MediConnect plan, but they're not in network. That provider can bill the Cal MediConnect plan retroactively within the 30 days in order to get payment and reimbursement for the services rendered, even though they didn't know you were in a Cal MediConnect plan and you didn't initially request continuity of care, as long as the criteria is met. And then finally, I guess the ultimate continuity of care protection, and this under Cal MediConnect, is the ability to disenroll from Cal MediConnect, because then you'll go back to either Medicare fee-for-service or some other Medicare plan that you might choose, but then you can gain access to the Medicare providers you might not have had access to under the Cal MediConnect plan. You can disenroll at any time for any reason. That disenrollment becomes effective the first day of the following month. Keep in mind, though, that even though you're disenrolling from Cal MediConnect, you are still going to be enrolled in a Medi-Cal plan for your Medi-Cal benefits. Only the Medicare side is voluntary. And just a quick review of what continuity of care looks if you're just on the Medi-Cal side. So maybe you are someone who only has Medi-Cal. You're going to be able to, the continuity of care on the Medi-Cal side is for 12 months. You have to have the existing relationship. It's the exact same kind of qualifications. And then even if you opt out of Cal MediConnect, so you're only in a Medi-Cal plan for your, basically you're in the Medi-Cal plan for your long-term services and supports, and you're in a facility that's out of network, you're going to be able to continue residing in that facility. So same continuity of care protection on that side as well. Right. The final thing I'll say about the Medi-Cal managed care continuity of care is that individuals who only have Medi-Cal, so they don't have Medicare, still have the availability of the medical exemption request, or the MER. It's available in the 2 plan counties and the geographic managed care counties of San Diego. It allows you to stay out of managed care entirely, but it's only available to people with complex medical conditions And again, the MR is not available to dual eligibles, only to individuals who have Medi-Cal only. And the reason for that is that your Medicare providers are being paid for by Medicare. So if you're not in a Medicare plan, you're only in the Medi-Cal plan, a MR does not apply. All right, and I'm going to switch it back over to Silvia now. I don't see any questions.
Yes, it doesn't seem like it. I think we've been so crystal clear that no one can think of anything. But really, we're happy to have any of those questions come. I'm just going to cover a few more of the final consumer protections, which are pretty critical. One, you do have a right to receive materials and services in your language, in a different language, and in alternative formats. And this will apply even if you are someone who does have someone if you're a Medi-Cal or Medicare beneficiary who has someone to assist you. I mean, it's still important to be able to read and understand what's happening to you, especially around passive enrollment, especially when you're entering a new plan, maybe making decisions about providers. So it is possible you can request a language that's better for you, a written language that's better for you, or alternative formats such as Braille or a CD. There are a number of accessibility rights. There are federal and state disability rights laws that apply. You can get reasonable modifications so that you can gain full and equal access to services. So alternative formats is part of that. Also physical accessibility when you visit your providers, especially if you're entering a plan and you do have to see some new providers and you go to a provider's office and you find that they are inaccessible to you. The exam tables don't lower, there is no elevator, there's not enough room for you in an exam room. That is a reason to say that you need physical accessibility. You can bring that up with the plan. You can bring it up with your provider. Also, the plans are required and have received training on disability discrimination and cultural competency. So that's something that they have an awareness of. So when you speak to the plan representative, they should understand what you're talking about. If you say that you have a complaint about inaccessibility or you have a need related to accessibility. Just going on to the next. And finally, there are some really key organizations, California organizations that can help when you're encountering a problem, when you're faced with choices as you join a plan. The HICAP is a California nonprofit organization that helps us, and it has especially expertise in Medicare. So for those who are thinking about joining a dual eligible plan, they can provide you with some independent advice and information, or if you're encountering problems as a dual eligible, they are a good place to go. Also, the CCI has an ombudsman set up, particularly for those who are facing healthcare changes and issues as they go through this process of being enrolled in a plan. Their number is up on the screen as well. They're a great resource they are all over the state, a number of legal service organizations, and they can often help you resolve issues that come up. Let's say the plan is confused, for example, about you're trying to get DME under Medi-Cal, and for some reason the plan wants to apply Medicare rules, which include the fact that your DME equipment has to be used in-house. For example, you have to use your wheelchair inside the house, and that's just not the case. Well, that's a confusion. The Medicare rules shouldn't be applied to that. And talking to the ombudsman and getting an advocate or an attorney to help you with that can help resolve it at the plan level without having to push it further. So that's some information for you, and we also have our information up there right now, Justice and Aging's website, and they have a great lots of resources on their Duals Demo Advocacy website. Our information is up there as well, and also the Department of Healthcare Services has a site, the Cal Duals website, which has a lot of information. And I realize that there is a question that has come up that I'm going to actually bring it up to everyone because I think it's a good one for everyone to think about. A question here about confusion about did we say that doctors often don't bother to bill for the additional 20% because the Medi-Cal rate is so low? No, I don't believe we did say that. It's that providers have been confused about the fact that they can get reimbursed for their 20% through a plan. Amber, do you want to speak to that some more?
Yeah, I do think that historically we have seen a great number of Medicare providers who serve duals who don't even bother billing Medi-Cal because they know they're not going to receive any higher of a rate than they're going to get from Medicare, and they just know that administratively it's just going to cost them money to bill, so why even do it? There is sometimes an automatic crossover process where if they bill Medicare, Medi-Cal's already billed when it was in the state. Now they're going to have to bill the health plans. But generally speaking, yeah, the rate's so low that they're not probably going to see anything, and a lot of providers know that. But there are other providers, and there are some instances where you are going to see the 20%. And where the confusion comes in is that instead of billing DHCS now, you're billing the plans. And so providers think that they need to be contracted with the plans as a network provider in order to bill them, and that simply is not the case. They just have to there's like a very short form that says that we're going to bill you, and that's how it works. And then on the provider toolkit online, there is a spreadsheet that shows how you bill each plan, how a provider would go about billing each plan. It has the way that you submit claims to each of the Medi-Cal plans as a Medicare provider. So again, I highly recommend using the provider toolkit in order to help educate Medicare providers on that process. And then, Silvia, I saw that there was one other question. It says that why do some clients who are on dialysis still enroll in the CCI? The question kind of has a lot of sub-questions in there. So some patients who are on dialysis have to, no matter what, have to enroll in a Medi-Cal plan. If they're dual eligible, they have to enroll in a Medi-Cal plan. It's individuals who have an end-stage renal disease diagnosis that are excluded from Cal MediConnect. So they shouldn't be getting Cal MediConnect notices. There are two exceptions to that. One exception is if you were already enrolled in a line of business that's operated by the Cal MediConnect plan, you'll get Cal MediConnect notices. To give an example, because that's just confusing. Let's say you're in HealthNet for your Medi-Cal and you're getting dialysis. Then you would get Cal MediConnect notices from health, and with your default plan being HealthNet, because you're already enrolled in a HealthNet business product. So you're enrolled in a plan operated by HealthNet, so you're going to get notices. So that's one exception to the end-stage renal diagnosis, disease diagnosis for enrollment. The other is if you reside in either San Mateo or Orange County, you also are going to get Cal MediConnect notices if you live in one of those two counties. And I think the reason that the behind-the-scenes rationale is that that health plan is already involved in your care somehow, and so it's not as disruptive to the entire case management, because individuals who are on dialysis have a lot of care coordination going on a lot of times with their regional centers, and that the point of excluding them was because they didn't want to mess with that coordination that's already in place. But if you're already enrolled in one of the health plan's product lines, which you are in Orange and San Mateo County or in any of the other counties, then you're going to get notices about Cal MediConnect. If you want to, Ludris, if you want to follow up with me offline on that too, you can just send me an email.
There actually are also 3 additional questions in the Q&A, and I'll just go ahead and take a couple of the first ones and give the third one to you, Amber, I think. One of them was, does a CMC opt-out dual who picks a Medi-Cal plan have continuity of care for DME providers? And that was asked earlier on, and I think Amber answered it later, but no, you do not have continuity of care for DME providers, even though DME is often especially when it comes to wheelchairs and seating, is a pretty highly individualized, some would say an art. But I'm afraid that the continuity of care, both for Cal MediConnect and for Medi-Cal, just for straight Medi-Cal plans. Continuity of care does not include DME providers, and that's been something we've fought, but that does seem to be the bottom line at this point. Someone asked the question, what exactly allows someone to be passively enrolled? If you fit in the categories, if a beneficiary fits in those categories, you're a dual eligible, you don't have share of cost, you don't have, you're not in one of the special other categories, you're a Native Indian or you're in the HIV waivers, et cetera. In general, if you're a dual eligible, you can be enrolled by doing nothing. That's what passive enrollment means. You get the notice. It tells you to pick a plan. If you do nothing and don't pick a plan and don't send anything back, you will be passively enrolled in a plan according to an assignment algorithm that the state is using. And then you will have to actually actively do something to get out of the plan, the Cal MediConnect plan, and then you will still be in a Medi-Cal plan because that's the only way you can receive Medi-Cal services now. Amber, if you have anything to add to those, and then there was a third question. Do you want me to ask it, or?
No, I had nothing. No, nothing to add to that.
Okay. The third question is, could you speak a little about the problems caused by the passive enrollment on Medicare, returning Medicare as it was, and possibly best practices in resolving? Working that out, best practices in resolving problems when passively enrolled in Medicare. I think that's what it may be getting at.
Yeah, I think, well, I guess the major issue that happens when someone's passively enrolled into a plan, there could be no disruption. That's possible. But most likely what happens if you're enrolled into a plan is that one of your providers is not going to be part of the health plan's network. And the whole point of the continuity of care protections is that even though maybe your providers aren't in network, you'll continue to be able to see them at least for 6 months in order to make sure that your transition into the health plan, your health care, your access to services isn't disrupted. So the continuity of care protections are in place because there's a recognition that you are not going to have all of your providers within a single health plan. And you may decide, there are options then once you're enrolled. So you're passively enrolled and you continue to see your providers with continuity of care, and things go pretty swimmingly and you're pretty happy, you're getting some care coordination, you're happy with your health plan, you can just stay enrolled. You may eventually change providers to in-network providers only, but that would be over a 6-month period possibly. So that's kind of one option. There's also, a scenario where you join the Cal MediConnect plan and continuity of care doesn't work exactly as it should. So you experience some disruption. Some people may decide to stay in, but other people might disenroll just so that they can keep access to their out-of-network Medicare providers. So not only have we seen a high percentage of opt-outs, so that means people choosing not to participate in Cal MediConnect prior to their effective coverage date in the program, so they're getting out of it beforehand. But we're also seeing a pretty large percentage of people who, once they are enrolled, decide that they're going to disenroll and put their Medicare back in fee-for-service. But with that, Cal MediConnect is a combined program. So your Medicare and your Medi-Cal benefits are being held by one health plan. When you opt out, no matter what, you're going to be in a Medi-Cal plan. And so like we've discussed throughout the webinar, there are some kinks with that. And there certainly is no coordination. So your Medicare providers aren't going to be talking to your Medi-Cal plan, and your Medi-Cal plan's probably not going to be talking to your Medicare providers. So that coordination that Cal MediConnect is supposed to offer is something that people who opt out don't get. But that may be the best option for someone because they want to make sure that they maintain access to their Medicare providers who aren't in any of the Cal MediConnect plans. So there's a lot of different scenarios and a lot of different ways to help resolve disruption, whether it's better education about the continuity of care policy, a more expansive continuity of care policy, one that is more broad, that offers more protections. There's also, issues when people opt out and maintaining access to their Medicare providers and their Medi-Cal only covered services. So there's a bunch of stuff that goes along with that. I hope I covered some of it.
Yes, I think so. They have a little, the person has a little bit of expansion in that, but I also want to cover, I know we're past time, but there was one last question that rolled in, and I thought I would pick that up. Can you discuss emergency disenrollment? A client kept her dual mom from having to pick a Medi-Cal plan. She argued that the transportation authorization requirements of the plans were more burdensome than in fee-for-service Medi-Cal.
Did she win that argument?
I'm sort of astonished that it worked, actually. Maybe we should talk more about that. It seems amazing that someone would win that argument. I think it can definitely be valid that the individual could have had more burdensome authorization requirements with the plans, but it's just what's surprising to me is that the plans allowed it. And then the person wrote that yes, the plans required her to call more regularly. I agree that there could be some additional requirements on the Medi-Cal side that weren't there before, but I don't think that rises to the level of being able to obtain a medical exemption request. Which is really the only way to have stayed out of the Medi-Cal plan. It's possible that it happened. I think it's pretty unusual, and it would be a hard argument to make. I think that since they're more, it's getting more individualized, maybe we can do that on email. There's another one. Do you believe Cal Medi-Cal plan is more dynamic than straight Medicare as far as the level of coverage and providers? I think it is. We've had that in other presentations as well. How much it is a personal decision, whether the plan is going to offer you benefits that make it worthwhile for you to join it, or not. And it's hard to tell without actually being in a plan for a while, at least, and seeing if that care coordination is something that's helpful. With with just a straight Medi-Cal plan, the care coordination element is less of a defined thing. But with a dual plan, it's clear, I think, that there is care coordination in what it's supposed to be. So joining a Cal MediConnect plan does have some benefits and can be very useful to someone. As far as the level of coverage and providers, I don't think a plan, in general, I don't think a plan will offer you a greater depth or more access to providers than fee-for-service Medicare. By its nature, you will be restricted in general to the plan's network. So if that's your greatest concern, to have the widest possible choice of providers, then a plan may not be for you. But then on the other hand, a Cal MediConnect plan will offer you care coordination and other benefits that you don't get from fee-for-service. So it's not a straight comparison of levels of coverage and providers. It's a little more complicated, and that's why it's important in a complicated situation, in a beneficiary's complex situation, to sort of really talk through all their options and their own needs.
Yeah, I agree. And there's also just wide variation among the health plans.
Yes, that's absolutely true as well.
That makes it very, not only is it beneficiary specific, but then what health plan you want to choose is, a big consideration. So.
Yeah. So I think as for any individuals who still have particular questions they want to follow up, please feel free to email us. Thank you for your questions. It always enlivens a presentation to have real questions and real situations. And I think we're done for today.
Sounds good. Thank you, Silvia. And thank you, everyone, for your participation.
Thank you, Amber. Bye-bye.